Hello, thank you for joining me today. My name is Meghan Thompson, and I'm going to be presenting a quality improvement project for the Doctor of Nursing Practice Program for the Catherine McCauley School of Nursing with Maryville University. And the project is going to be discussing decreasing emergency department visits among patients without a primary care provider. This slide is just to recognize the committee members that assisted me throughout this process of implementing the project. My chairperson, Dr. Dawn Matz, my community member, Dr. Jonathan Thomas, and our Nurse 705 course faculty, Dr. Boniface Stegman. So to touch on the background and significance of this project, the primary project aim was to decrease unnecessary emergency department revisits among patients without a primary care provider. The PICO question that was posed for this project specifically stated in outpatient ED patients with no primary care provider, how does the intervention of providing a physical handout resource with a primary care provider hotline compared to no intervention impact revisits to the ED 3 months before the intervention and 3 months after the intervention? So to touch on the background of why this project was important to implement within the emergency department, we all know in healthcare that primary care providers are an essential part of healthcare. They help with continuity of care. They manage chronic conditions. They manage medications. They do our annual wellness visits, all the things that are essential for maintaining overall quality of health. However, over 40 million Americans do not have a primary care provider, which puts them at risk for, worsening of chronic conditions and not catching those acute illnesses that they need to be treated for. And unfortunately, patients that don't have a primary care provider do use the emergency department as a source of primary care. This causes several issues, including decreased continuity of care, overall poor patient health outcomes, and it also leads to substantial increased healthcare costs and increased patient mortalities. Since 2010, the cost of unnecessary emergency department visits have actually doubled, and an estimated $8.3 billion is spent on visits that could be handled appropriately in a primary care provider setting. It's also stated that there is a high admission rate among patients who visit the emergency department 30 days after their visit if they don't follow up with their primary care provider. 56% of ED visits are actually avoidable and can be appropriately managed in a primary care setting. However, there is barriers that patients face to obtaining a primary care provider other than just not wanting to get one or not knowing how to find one, and this includes social determinants of health that prevent them from doing so. However, the implementation of an intervention in the emergency department that we will discuss has actually shown an increased PCP usage in the ED as high as 63%. To discuss a review of literature for the project, there was a primary study that was utilized to guide this project. It was actually conducted in Berlin, Germany by Holzinger and his associates, and it involved distributing a intervention in the emergency department to patients to assist them in obtaining a primary care provider once they left the emergency department. The strengths of this study included that, there was increased use of primary care providers once they were discharged. The previous slide showed that there was a 63% use of PCPs once they received the intervention. However, the weaknesses of this is that only one study has been published so far that supported the use of this intervention. The study also had a relatively small sample size. There were only 116 participants in the study, and there was unfortunately no change in the use of the ED as a primary care source, even though there was an increased use of primary care providers among the patients that received the intervention. There were several studies that were reviewed by the author to analyze interventions to decrease ED revisits among patients without a primary care provider. Some of these interventions included using patient navigators in the ER that would actually initiate follow-up appointments for patients that didn't have a PCP, and also follow-up phone call reminders were initiated to help patients remember that they had an appointment with a primary care provider or that they needed to schedule an appointment with a primary care provider, and this did increase PCP usage. Currently, there are no specific guidelines that support an intervention to help patients obtain a primary care provider in general or once they are discharged from the emergency department. And this specific intervention that was implemented for this project was selected due to staffing shortages within the facility that the project is implemented and the inability to implement a complex intervention due to lack of staffing to be able to do so. There were also multiple studies that were reviewed to support that social determinants of health do affect patients' ability to obtain a primary care provider once they are discharged from their emergency department. And the primary social determinants of health that were identified were poor health literacy, lack of knowledge of facility use, so not really understanding the difference between why they should see a primary care provider or why they should go to the emergency department based on their overall illness. Homelessness or inadequate housing, ethnicities, people that are not Caucasian face difficulty obtaining a primary care provider, low income status, lack of finances, and also a lack of transportation. The theoretical framework that was used to guide this project was the health belief model. And this model explains the relationship between an intervention initiated and the effects that it has on the patient population. So it focuses on preventive healthcare practices, which is the primary objective of this project is to implement preventative healthcare with a primary care provider so that we can improve continuity of care and decrease poor health outcomes among patients. The model also addresses assessing patients' concerns regarding their health. Patients have to understand that there is a need, that they need to have a primary care provider to improve their overall health. And then also it touches on barriers preventing patients from obtaining treatment for their illnesses, which, as we're going to discuss, social determinants of health prevent patients from obtaining a primary care provider. The key concepts of this model include perceived susceptibility, severity, benefits, barriers, self-efficacy, and cues to action, which these keys are important to this model because patients have to be aware of these key concepts in order to want to improve their overall health. And healthcare providers and medical staff also have to be aware of these key concepts to advocate and assist patients in obtaining a primary care provider and improving their health. So the methods and design of this project. The project was implemented in an emergency department in a rural metropolitan area in south central Kentucky. The facility where this took place sees an average of 40,000 patients annually in the ER. The project is a quantitative design, and this was selected so that two groups can be compared to evaluate for intervention effectiveness. And the project was based on an intervention implemented and then also a retrospective data analysis. The primary implementation method involved registered nurses. They identified patients without a primary care provider either during triage or prior to discharge, and they administered the handout resource, which contained the primary care provider hotline that the patient would call once they're discharged from the ER to obtain a primary care provider. They also received a project flyer, which described the project and that they would be receiving a follow-up phone call for post-intervention surveys. And they also received an oral consent form so that they could consent to the post-intervention surveys once they were called by the author. And this implementation period of the intervention took place over 3 months. So this was implemented by educating the registered nurses during shift huddles. They were educated on both day and night shift huddles over several days, over a week. The project description was also posted on a secure work-only social media app so that it could be used to reference over the data collection period so that nurses could remember why they're implementing this intervention and what the cause is. And the data collection involved registered nurses placing a demographic label in a binder that was kept in a locked cabinet behind the nurses station. The demographic label contained the patient's name, date of birth, account number, and visit date. And this was collected to track who received the intervention so that they could be called for post-intervention surveys once the data collection period was over. This slide just shows the resources that were used during the intervention period. On the right is the Need a Doctor phone number. This was the resource that was provided to patients that they could call either number, and they would be directed to a hotline that would assist them in obtaining a primary care provider. And on the left is the project flyer that was given to each patient during the implementation period, and it explained why they were getting this resource. They would be contacted for post-intervention surveys, that they were selected due to not having a primary care provider at the time of their emergency department visit. The pre-intervention retrospective data collection involved obtaining a list of patients 3 months prior to the intervention process, and a random number generator was used to select 82 pre-intervention patients during a 3-month period prior to the intervention period. Post-intervention phone surveys were also collected. These survey answers were recorded on a de-identified data sheet, and it assessed the use of the resource to obtain a primary care provider. So this included, did they use it to obtain a PCP, yes or no? Did they revisit the emergency department after receiving the intervention during that 3-month period? And then if they completed the survey and they did not obtain a primary care provider, the Accountable Health Community's health-related social needs screening tool was administered to analyze if they did face social determinants of health that may prevent them from obtaining a primary care provider. The AHC HRSN tool that was utilized in these post-survey interventions for patients that did not obtain a PCP with the resource addressed specific sections of the tool. It had over 25 questions, but only 8 questions were selected for this project. These questions involved asking about lack of finances, transportation, appropriate housing, assistance with day-to-day activities, language barriers, meaning that they spoke a language other than English, and then if they had any physical, mental, or emotional conditions that prevented them from doing errands, concentrating, remembering, or making decisions. And prior to initiating these surveys, patients were made aware that they did not have to answer any questions if they felt uncomfortable, but that all of their answers were kept confidential throughout the entirety of the project. And the methods and design snapshot of the time period for the project is displayed here. This involves the planning phase, the needs assessment of what the intervention was going to be for the project, which is the implementation of the resource for patients who don't have a primary care provider, collaboration with departmental heads that were essential in implementing this project, including the ED director, the director of physicians, the Vice President of Quality and Safety, the Chief Operating Officer, the Director of Facility Communications, the ED Practice Improvement Specialist, and ED nursing staff. And this took place between September 1st of 2024 and November 1st of 2024. The development of handouts was implemented. The author developed the project flyer and oral consent forms. This was between November 15th and January 20th of 2025. IRB approval was obtained. This was between August 14th and September 24th of 2025. The staff were educated about the project and the necessity for the intervention. This occurred between September 24th and September 30th of 2025. And then the project was implemented between September 29th and December 29th of 2025. And finally, the results period was between January 8th and January 14th of 2025, and this involved data analysis and post survey phone calls. The sample for the project involved 82 pre- and post-intervention patients for a total of 164 patients. The inclusion criteria for the project was that patients could not have a primary care provider at the time of their visit, and they had to be ages 18 through 89. The exclusion criteria was that the patient had a primary care provider at the time of their visit, they were younger than 18, or they were older than 90. Data analysis involved a one-tailed lower tail z-test for the difference of two proportions. This specific test was used to compare pre- and post-intervention groups to evaluate for statistical significance of the intervention and whether it made a difference in ED revisits among patients without a PCP. SPSS was used to analyze the data. The information was input into SPSS to obtain the data for pre- and post-intervention groups, and then Excel spreadsheet was used to organize the data once it was analyzed in SPSS. Overall, there were 90 total participants that received the intervention. However, 8 did not meet inclusion criteria due to being underage, so only 82 patients were used in the project. The z-test statistic was set at 0.5605. The power of the project was 0.138864, and a p-value to analyze for significance was set at 0.05. For pre-intervention patients between June 28th and September 28th of 2025, it was found that 21% returned to the emergency department and 79% did not return. And the post-intervention patients, so those that received the intervention to obtain a PCP, 24% returned and 76% did not return. And on the right side, this shows pie charts of the pre-intervention and post-intervention. The orange is the did not return to the ER, and the return is in blue. After the post-intervention surveys were initiated, 32% did not answer the phone. 16% had an incorrect number listed, which means that they were unable to be contacted. And 5% already had a primary care provider, which may have not been listed in their electronic medical record at the time of triage or discharge. However, 48% of the 82 participants did answer the phone. 34% completed the survey. 5% of those used a resource to obtain a primary care provider, and 5% did not complete the survey. So the results of this showed that the post-intervention group had slightly more ED revisits compared to the pre-intervention group. This shows that there was no statistical significance to suggest that the intervention decreased emergency department revisits among patients without a primary care provider, and the data supported this as the p-value was 0.7124, which was higher than the set p-value of 0.05, and the z-test statistic was negative 1.9600. And also, 57% of patients who completed the post-intervention survey using the AHC HRSN experienced at least one social determinant of health that affected their ability to obtain a primary care provider. This chart shows the amount of patients that experienced a social determinant of health. It's organized by the questions that were asked, so decision-making, language, daily activities, errands, food, finances, transportation, and adequate housing. In the orange, you see that these are the patients that did not have any difficulty with these social determinants of health, meaning that they did not experience a social determinant of health. However, the blue bar shows the amount of patients that did experience a social determinant of health that may have prevented them from obtaining a PCP, even though they were giving a resource to do so. Limitations to this project involved a small sample size, so only 82 patients received the intervention. This caused a low project power, which means that the results of this study are not likely applicable to the general population due to it being such a small number. This was also an inadequate length of time for the intervention implementation. Long-term implementation of this intervention may progressively cause more decreases in ED revisits as more patients obtain the intervention to get a primary care provider. However, 3 months is not enough time to show that long-term effect. Few patients completed the post-intervention survey, only 28 did so, so this also decreases generalizability to the general patient population. And a significant limitation is that only one study was published implementing the intervention of the handout resource in the ER to help patients obtain a primary care provider. So the primary discussion for this project is that providing patients with a handout to obtain a primary care provider does not decrease ER revisits. However, the survey tool used to screen for social determinants of health reveals that several patients experience this, and this prevents them from obtaining a primary care provider. Unfortunately, after completing this project, it is identified that a significantly large gap exists within the healthcare system that fails to address patients who experience social determinants of health, and overall this leads to increased morbidity and mortality among this patient population as they are not able to obtain a primary care provider to experience continuity of care and manage their overall health. Implications for practice involve healthcare staff because they are the primary drivers for advocating for patients and to help patients, all patient populations, obtain access to health care. Patients should be screened for social determinants of health so that we can address these disparities affecting their health, because patients are not routinely screened in the emergency department for social determinants of health. And providers and staff should also educate patients experiencing social determinants of health of resources available to obtain medical care if they are not able to obtain a primary care provider, so that they can at least get some form of health care to try to manage their overall health long term. The conclusion for this project is that the intervention did make an impact on the nursing staff in the department. There is an increased awareness of the need to help patients obtain a primary care provider, and the resource also continues to be available in the department. Prior to this, I don't believe that nurses were very aware of the amount of patients that do not have a primary care provider, or just not as focused on that being an overall issue until this intervention was implemented. 4 patients did obtain a primary care provider with the intervention, which is a relatively small number. However, this is a good thing because 4 patients that did not have a primary care provider do now, and this will help improve their overall health long term. Future improvements for practice, or even future improvements for re-implementing this project, could be to use text message communication. A lot of patients did not want to answer the phone, or once they answered the phone and just had to speak over the phone, they just weren't interested or said that they didn't have time. Interventions like appointment scheduling would be beneficial. However, there were not enough staff in the emergency department to dedicate a specific person to schedule appointments. And also having dedicated staff in facilities to help patients obtain a primary care provider would also be beneficial, as it showed to be beneficial in previous studies that were reviewed for this project. More research definitely needs to be conducted to determine the most successful method for helping patients obtain a primary care provider. As discussed earlier, there are no set guidelines to help patients obtain a primary care provider. There have been several interventions that have been trialed within studies, but none of them show a specific path to show what intervention would be the most successful. Standard guidelines need to be implemented regarding the best practice of helping all patients, including those with social determinants of health, obtain a PCP. And further studies also need to be addressed to see what interventions can be implemented for patients experiencing social determinants of health. These patient groups experience significant healthcare disparities, and they do not have access to healthcare. So further studies need to be implemented to see what can we as a healthcare community do to assist these patients in obtaining primary care so that they have an equal opportunity to receive healthcare as other patients who are not experiencing social determinants of health. This project for the author shows an increased awareness of the patients that experience social determinants of health. I feel like throughout, nursing and going to school and having education, you know that there are patients that experience this issue. However, you're not always dealing with it firsthand or seeing it or analyzing data that shows just how many people experience this. However, this project has really brought to light that a lot of patients experience this, and this severely affects their overall health. I've also learned that patients need to be educated of the resources that are available to obtain care, and this can include health fairs, local facilities that offer local housing, transportation options within the community, and also financing options that are available for patients who experience social determinants of health. And I've also gained an improved perspective of patient needs within the community, and that they face so many social determinants of health, even just difficulty obtaining food or transportation or not having a safe place to live, that can affect their overall health and just overall being as a person. Throughout the Doctor of Nursing program, it has definitely strengthened my perspective on the need to advocate for patients, to really bring to light the struggles that they face, and to really advocate to primary care providers, or even as a future provider, to step in and say, hey, what do you need? What can we do for you today, so that we know that you're in better hands and in better care than when you leave this department. Providing evidence-based practice and holistic care is essential. I think nursing does a really great job overall of, you're treating the person as a whole person. You're not just treating one illness, one abnormality. You are treating them as a whole person, spiritually, emotionally, mentally, physically, pathologically, all of it. It all needs to be addressed to make sure that their overall health is at the utmost standard and of utmost importance. Patient education, I've also learned, makes a substantial impact on health outcomes and quality of care. And this really revolves around how you speak to the patient. Do they understand your terminology? It can be easy to use terminology that we are familiar with as healthcare providers or healthcare staff, but it is getting down to their level and making sure that they understand their overall health and addressing any concerns that they have, so that whatever issue they're facing does not continue to be an issue long term. And also, I have learned significantly that teamwork is very essential in healthcare, whether it be consulting another provider, talking to your nursing staff, involving social work, consulting physical therapy or a specialist. This is so essential that we all work together, because the patient is the primary reason that we are here in healthcare. They need us, and it is our job to work together to make sure that they have an overall great quality of care. I appreciate you listening today. I hope that you have learned something from this project. These are the references that were used for this project, and I really appreciate you listening. And please know that you can reach out to me or email me if you have any questions. Thank you.